It's 7:30 a.m. at Kutali Hospital. Nurse Nuru and her supervisor in charge Sela are on a supportive supervision visit to Kutali Sub-District Hospital. The nurse on duty, Nurse Fatima, has 34 patients to register today. The solar battery is at 40%. The shared tablet shows 1 bar of 2G. Comcare hasn't synced since yesterday. The nearest IT support is in Mwisho, 60 kilometers away. The nurse has a device, she has the app, and she even has a password, but she still can't fully use it. Which level of the digital divide is Nurse Fatima facing? Access, use, or impact? Keep going. The episode will answer it. Hello and welcome back to First Elevate Africa Digital Literacy Series. I'm Vivian Korir. Today's episode addresses one of the biggest misconceptions in digital health, that giving someone a digital device automatically means they are digitally empowered. The reality is very different. Across Africa and many low and middle income countries, millions of health workers now have smartphones, tablets, and computers. Digital health systems continue expanding rapidly. Electronic community health information systems, digital reporting tools, telemedicine platforms, and AI are becoming increasingly common. Yet many health workers still struggle to use these technologies effectively. Why? Because digital inclusion is more than owning a device. Today, we'll explore the digital divide, not simply as an issue of internet connectivity, but as three interconnected levels: access, use, and impact. By the end of this episode, you'll understand why these three levels matter and what health systems can do to close each gap. Today, we'll define the digital divide and its three levels, understand barriers experienced by frontline health workers, learn why access alone is not enough, explore practical strategies that work in low-resource settings, and discuss why equity and gender matter in digital transformation. Let's begin. Before we go into the concepts and definitions, I want you to have a very clear picture of Kutali Hospital, because everything we discuss today becomes real only when you can see it in a specific place. Kutali Hospital is a sub-district health facility more than 60 kilometers from the nearest town, Mwisho. When something breaks, a tablet, network connection, forgotten login, the round trip to IT support is a half working day. Power runs on solar. That sounds modern, but it means everything depends on the weather and the battery charge level. At night, there is no digital access at all. Connectivity, 2G at its best. Pages load slowly, large training videos cannot open, real-time data sync is not given. It's an achievement. Devices are shared, 1 tablet per ward, 3 nurses, a logbook to manage who has it and when. The systems are Comcare for patient registration and DHIS2 for aggregate district reporting. But here is the real picture. Most data starts on paper. It migrates to digital only when there is power, connectivity, and time, which is rarely all three together. And IT support is 60 kilometers away, available by phone when the signal is available. WhatsApp calls are more reliable when power is available. This is Kutali, and this is not unusual. Across sub-Saharan Africa, this is the everyday reality for hundreds of thousands of health workers. Keep Kutali in your mind for the rest of this episode. Everything we discuss, its workforce, leave it. What is the digital divide? When many people hear the phrase digital divide, they immediately think about internet access. While connectivity is important, today's understanding is much broader. The digital divide refers to the inequalities that prevent people from benefiting fully from digital technologies. The divide exists at three levels. First is access. Can health workers obtain the tools they need? Do they have electricity? Do they have reliable internet? Is data affordable? Do they have suitable devices? The second one is use. Even when technology is available, do health workers possess the confidence, knowledge, and digital skills needed to use it effectively? Third is impact. Does technology actually improve healthcare delivery? Does it save time? Does it improve decision making? Does it reduce paperwork? Does it reduce duplication? Does it improve patient outcomes, or it simply created another reporting burden? These three levels build upon one another. Without access, use is impossible. Without skills, access creates little value. Without meaningful impact, digital transformation becomes expensive digitization rather than the health system improvement. Let's look at each of the three divides. Access divide. Nurse Fatima shares one tablet with her colleagues. The battery dies by lunchtime. Electricity is unreliable. Internet coverage disappears during the rainy season. Data bundles are expensive. Sometimes she walks several kilometers to simply upload reports. This is access divide. Technology exists, but access is unreliable. Notice something important. The problem is not willingness, it is infrastructure. No amount of motivation can compensate for a dead battery or network coverage. Now suppose connectivity improves. The tablet works. The internet is available. Does that solve everything? Not necessarily. Skills gap. Nurse Fatima was never trained to navigate ComCare and DHIS2. She did not do a digital literacy module in her pre-service. She worries about making mistakes. She struggles with passwords. Safety gap. At Kutali, patient data is usually shared via WhatsApp since it's faster. No awareness on phishing. Fatima clicked a suspicious link last week. Privacy breaches erode community trust in digital tools. Language gap. The digital applications in Kutali are in English, yet there are three official languages in the country. Navigating the app is not easy. Some health workers have low literacy, limiting effective use. Confidence gap. Fatima fears looking incompetent in front of her colleagues and patients. There's no safe space to make mistakes, and there's no one to ask basic questions. She doesn't know how to troubleshoot software. When an error message appears, she becomes anxious. She fears clicking the wrong button. Male colleagues assume she just doesn't understand tech. Low confidence means delayed data entry and thus poor data quality. This is the use divide. Digital literacy is not simply knowing how to operate a smartphone. It includes finding information, evaluating information, communicating digitally, managing data safely, solving problems, protecting privacy, and increasingly working responsibly with AI. Confidence matters just as much as technical knowledge. Now imagine Kutali Hospital has excellent internet and Nurse Fatima has received training. She confidently uses ComCare and DHIS2. Has the digital divide disappeared? Not yet. This is level 3, the impact divide, the gap between using a digital tool and actually improving patient outcomes. Fatima still records patient information on paper, then enters into ComCare and later into DHIS2 for district reporting. The systems don't fit her clinical workflow. As a result, patient data lacks visibility. Then come missed alerts. A stockout notification is sent through the system, but notifications are turned off to save battery. The alert is missed and the facility runs off essential supplies like ORS for days. The extra documentation and navigating multiple systems leads to burnout. Instead of spending time with patients, Fatima spends valuable clinical hours translating information, troubleshooting systems, and repeatedly entering the same data. This contributes to delayed care. Actionable information does not reach decision makers or lower level facilities in time. So preventive action is missed and patients often present only when their conditions have become more severe. There's also the real cost. Incomplete or delayed records lead to poor resource allocation. District decisions are made using data that do not reflect the reality on the ground, and ultimately, patients pay the price. And finally, we have the algorithmic bias. If digital tools are built on incomplete or unrepresentative data, They produce less accurate recommendations for already marginalized populations, reinforcing existing inequalities rather than reducing them. This is the impact divide. Digital transformation is not successful because health workers use digital systems. It is successful when those systems reduce workload, support clinical decision making, improve service delivery, and ultimately lead to better patient outcomes. Closing the impact divide requires more than technology. It requires interoperable systems, human-centered design, workflow integration, trusted data, supportive leadership, and continuous capacity building. Because the goal is not simply to digitize healthcare, but to make healthcare better. Now let's look at how Fatima bridges the digital divide in practice. She doesn't wait for perfect infrastructure. She works around it. She uses ComCare offline first, with paper as backup, and only syncs when connectivity is available. She plans digital work around power availability, keeps devices in offline mode to save battery, and turns on mobile data only during sync windows. The team follows shared device protocols to prevent data loss, learns together through a 15-minute peer learning cycles, and reports aggregate DHIS2 data when individual digital reporting isn't feasible. These aren't perfect conditions, but they are smart, low-cost, sustainable practices that keep health services running despite the digital divide. Another critical dimension of the digital divide is equity. Not everyone experiences digital transformation in the same way. Women, older health workers, rural facilities, people with disabilities, and those facing language barriers often encounter greater challenges. For example, women in low-income countries are 14% less likely to own a mobile phone. Female community health workers are 27% less likely to use digital health tools, and 885 million women without mobile internet are concentrated in South Asia and Sub-Saharan Africa, and 300 women remain excluded from digital financial services. Meet Fatima. She has to ask permission to use the tablet and misses digital health training because of caregiving responsibilities. Her experience reflects barriers such as limited device access, affordability, social norms, time constraints, language, and safety concerns. Digital inclusion means designing systems that work for everyone, not just those already connected. Digital transformation succeeds only when no one is left behind. So what can health systems do? Let's organize the solutions using our 3 levels. At access level, provide dedicated devices instead of shared facility tablets, invest in reliable electricity or solar backup systems, subsidize mobile data for frontline health workers, enable offline functionality so that applications continue working even without connectivity. At use level, embed digital literacy into pre-service education, provide continuous in-service training, use short practical micro-learning sessions, create peer learning circles where colleagues support each other, build psychological safe learning environments where mistakes become opportunities to learn rather than reasons to blame. At impact level, align digital workflows with real clinical practice, avoid duplicate data entry, integrate reporting across systems, strengthen supportive supervision rather than focusing only on compliance, ensure women participate in leadership, design, and decision-making, develop multilingual digital tools, and increasingly use intelligent offline applications that can predict local supply needs and support better decision-making even before reports reach district headquarters. Think about your own context. Which divide is most visible? Is it primary access, use, or impact that holds people back? Can you give a concrete example? Who's left behind in your team? Think about a colleague who struggles with digital tools. Is it a skills gap, a confidence gap, or a structural barrier? What would help them most? Paper to digital hybrid. Do you use paper as backup or primary system? Is your digital tool designed to work with your paper system or against it. Take 2 minutes, write one insight before continuing. Let's check your understanding. Fatima has a tablet, ComCare installed, and a login. She still cannot improve patient data quality. Which divide does this best describe? A. Access. B. Use. C. Impact. D. Infrastructure. Question 2. Which design principle is most appropriate for Kutali Hospital's digital health tools? A. Cloud-first real-time sync. B. Desktop optimized interfaces. C. Mobile-first, offline-first. D. Internet-dependent dashboards. Question 3. Nuru colleague shares patient names in WhatsApp group because it's faster. This is a failure at which level? A. Access divide, no secure channel. B. Use divide, safety gap. C. Impact divide, outcome gap. And D. Gender divide. Question 4. The ward has 1 tablet and 3 nurses. Which strategy best addresses this access constraint? A. Buy more tablets immediately. B. Let the senior nurse keep the tablet. C. Share device logbook with scheduled use slots. D. Stop using digital tools until resources improve. Take some time to reflect on each and I'll share the answers shortly. Let's check your responses. How many did you get correct? Question 1. The correct answer is C. Impact divide. Question 2. The correct answer is mobile first, offline first. Question 3. The correct answer is B. Use divide, safety gap. And question 4, the correct answer is shared device logbook with scheduled use slots. That brings us to the end of episode 10 on navigating the digital divide. Today we've looked at the 3 levels of the digital divide, that is access, use and impact, Fatima's real barriers at Kutali Hospital, offline first, paper hybrid strategies, gender and equity dimensions, and what meaningful impact looks like. Next week, we shall look at introduction to digital health. Thank you for joining us today. Remember, digital equity is health equity. Every health worker, whether in Kutali, Mwisho, Nairobi, Accra, or Lusaka, deserves the skills, tools, and support to deliver care digitally, safely, and confidently. Which level of the digital divide is the most visible in your health system? Share your answer in the comments. Repost to start a conversation in your network. Follow us for the full series.